Hello and welcome to Kaweah Health Town Hall. My name is Deborah Volosin and I am the Director of Community Engagement for Kaweah Health. We are so glad you are online and with us today. We are hoping to answer all of the questions that have been submitted and the chats that will come in live on this broadcast. The COVID-19 vaccine has been a hot topic since it first became available on December 11th, 2020. At any given time, any of us can get online and find articles and stories about or in support of whether or not to get vaccinated. In Tulare County, 32.9% of Tulare County residents are fully vaccinated. And just last week, the FDA gave its first approval of a COVID-19 vaccine. Our goal today is to answer questions that you have about the vaccine and hopefully clear up rumors or misinformation. Before I introduce our panelists, I want to remind you that during this live event, you can submit questions on either Facebook or Instagram, and you can also send emails to questions@kaweahhealth.org or text them to 559-280-9374. We have moderators on each of these platforms, and they will send those questions my way. The recording of today's event will be posted on our website and social media. We will also be doing a Spanish vaccine town hall in coming weeks. We will post that on our Kaweah Health Spanish Facebook page. I am joined today by two of Kaweah Health's medical professionals, Dr. Monica Manga and Ryan Gates. Dr. Monica Manga is the Chief of Staff at Kaweah Health. She is also a staff physician of internal medicine at Kaweah Health Medical Group, and she's the medical director of Kaweah Health's specialty clinic. Prior to coming to Kaweah Health, Dr. Manga was an assistant professor at a university in Colombia and a principal investigator at Visalia Clinical Research. Thank you so much for joining us, Dr. Manga.
Thank you, Deb. I'm glad to be here.
Ryan Gates serves as the Vice President of Population Health at Kaweah Health, where his main role is to oversee the rural health clinic system, the community outreach department, and the population health department. Dr. Gates is also the Vice President of Clinical Integration for Sequoia Integrated Health, where he is responsible for the clinical leadership and guidance of the organization. Prior to coming to Kaweah Health, Dr. Gates served as Senior Clinical Pharmacist and Residency Program Director at Kern Medical Center. Thank you so much for joining us, Ryan.
It's a pleasure. Thanks for having me.
All right. Well, we have received several questions, so we are going to jump right in. And Dr. Manga, I would like to start with you. Are there any differences in the effectiveness among the different available vaccines, and how well are the vaccines working?
The data on the efficacy of the vaccines come from various studies. They are designed differently. So I want to exert caution when we try to compare one study to the other. Having said that, it is true that the current available vaccines in the United States are showing a decreased neutralization power against new variants. However, they all remain very good at preventing severe disease. And I want to mention several studies that recently have been published. One of them was in England, and this was specific towards the Pfizer vaccine. And what this study showed is that after you get the first shot of the Pfizer vaccine, you are protected, or it shows an effectiveness of 30% against the Delta variant, compared to 48% against the Alpha variant. After the second shot, the effectiveness is about 88%, compared to 93% against the Alpha variant. A different study, this time in Canada, analyzed the Moderna vaccine. And what this study showed is that the vaccine is effective about 72% against the Delta variant, but 96% effective against severe disease. And the data released from the Johnson & Johnson shows an effectiveness against the Delta variant of about 85%. So in conclusion, vaccinations or vaccines continue to be effective in preventing you to getting the disease in the first place, and they're excellent in preventing severe disease and hospitalizations. Although not asked, I think it's important also to mention a couple of things. That receiving the vaccine decrease your infectiousness should you get a breakthrough infection, and also decreases your chances of developing long-term symptoms from COVID disease.
Okay, thank you, Dr. Manga. So Dr. Manga, for our current hospitalized patients who have COVID-19, who have been vaccinated, is there any data available on which vaccine they obtained?
No. So when the patient is admitted to the hospital, we do ask the question about their vaccination status. If the patient answers yes to the question, then that answer is validated through the vaccine registry. That is a very time-consuming and difficult process, so we don't follow exactly which type of vaccine the patient received.
Okay, are there any differences, Dr. Manga, in terms of the side effects of the different available vaccines?
Well, all of the vaccine cause something called reactogenicity. Basically, what this is your body's response to the vaccine. Kind of your immune system gets turned on. So if you encounter the disease or the virus, then you're ready to defend yourself. And because of that, you develop certain effects. They usually occur very rapidly. The most common ones are pain at the site of the injection, swelling and fever. Some people may have muscle aches and they rapidly subside. They do occur more frequently after the second shot of the mRNAs and in young people. And if for whatever reason you do not develop these effects, that doesn't mean that you have not turned immune against the disease.
Okay, thank you. So Ryan, we received this comment. Vaccines don't stop the spread, so it's only a therapeutic. Vaccines also don't stop a person from contracting the virus. Again, a therapeutic. There are many other effective therapeutics. Maybe if those were being discussed as often as the vaccines, we wouldn't be seeing hospitalizations. What are your comments on that statement?
Well, in the sense of the author of that question, I would emphatically agree that vaccines as a therapeutic in terms of the prevention of severe disease, it's not a therapeutic in the fact that you would administer it to somebody who is actively infected. So when you look at the weight of the evidence and what we're trying to do to prevent or treat severe COVID disease, vaccines are absolutely the most effective, powerful therapeutic, if you want to put it in that context, when we look at the overwhelming amount of evidence of the vaccine versus, let's say, ivermectin or hydrochloroquine or other medications that are used as true therapeutics for people who are have active disease. When you look at the evidence of the vaccine, and you would say that it doesn't stop the spread, that's simply not true. Again, one of the largest studies, they're coming out of Israel, honestly. When you have large countries that have that kind of centralized medicine, you have access to incredible amounts of data. And so they published a trial that, let me see, I want to misquote, but 596,618 people. That is a huge study. Normal studies have a couple thousand, but when the larger study you have on people you have involved in the study, the more confident you can be in the results. And so here we have a study, over 500,000 people, a 92% reduction in documented infection, 94% reduction in symptomatic COVID infection, 87% reduction in hospitalization, right? So there's your therapeutic piece, right? and a 92% reduction in severe disease. Another study came out just August 27th, so less than a week ago. And again, the data just keeps pouring in, but this came from LA County at a population. The study was 43,127 participants. So again, huge study. The study showed that unvaccinated people are 4.9 times more likely to become infected. And so therefore stopping the spread, right? Vaccinated people have less of a chance, 5-fold less chance of becoming infected, and therefore stopping the spread of the disease. And 29.2 times more likely to be hospitalized. So almost 30 times more likely to be hospitalized if you were unvaccinated. So again, from a therapeutic standpoint, absolutely vaccine the most effective, but in terms of prevention and stopping of the spread, of course, most effective as well.
Okay.
And we'll talk about therapeutics here in another question later on.
Okay, thank you. So Ryan, is there any truth to the rumor that the vaccine can give you COVID-19? We're hearing stories of people who are getting the vaccine and then a few days later they're being diagnosed with the virus. Is there any truth to that?
No, so there are live virus vaccines and much and more of the old school type, but that could have a chance of causing active disease because you're using a live virus. You're actually injecting people with live virus. But no, COVID vaccines are not live virus vaccines and cannot cause COVID infection. I do know of several people who in between their vaccines did get COVID. It's just simply the contagiousness of the disease and that they contracted the disease, the virus, just coincidentally to their vaccine pattern.
Okay, thank you, Ryan. But so say you unknowingly have COVID, there are asymptomatic people. So say you unknowingly have COVID and then you get the vaccine, can it worsen the virus symptoms?
So Dr. Manga mentioned in one of her answers, reactogenicity. So when you become vaccinated, you're ramping up your immune system, right, to build up a defense, a response to the active infection. So if you were unknowingly, so there are what we call asymptomatic carriers, right? People who have the virus or shedding the virus, but they don't really feel, maybe they have they feel like it was maybe allergies or something, a very subclinical response. But they have antibodies, right? And so if you get the vaccination, you could have a more robust response to it to build your immunity, and therefore have a little more aches, fevers. But typically those aren't severe. They wouldn't be mistaken for actual COVID infection, and they tend to go away pretty quickly. Dr. Manga, if you have anything to add to that.
Absolutely true, Ryan. And one thing that I want to mention regarding the prior question is that there is something called the incubation period. So if, I get in contact with the virus and I'm infected, it takes a while to actually develop the symptoms. That's what it's called, incubation period. So let's say I get in contact with the virus today. We know that the Delta variant has a shortened incubation period than other variants. So in about 3 or 5 days, it's likely that I will develop some sort of symptoms. But if I got my vaccine tomorrow and then I get the symptoms, not necessarily, or I get COVID-19, not necessarily, that was just coincidental. I already had the virus and the virus was incubating before I actually developed symptoms. And it is also important to remember that the protection takes a while. So we mentioned before about the 2 shots of the Pfizer vaccination and how the first shot have reduced effectiveness, and you need that second shot. And it takes 2 weeks after that second shot to develop immunity. And it also takes 2 weeks after the Johnson & Johnson to develop immunity.
Okay, thank you. So Dr. Manga, why should the approval by the FDA for the Pfizer vaccine mitigate the community's concerns when other medications previously approved have also been subsequently recalled? Do you feel this decision was rushed?
That's a great question. And I would like to start by answering that the decisions made regarding the approval of all the available vaccines in the US against COVID-19 have not been rushed. In fact, all of these vaccines have gone through rigorous studies and trials. To obtain approval through the Emergency Utilization Act, all of them had to go through the needed steps of research. And we have different type of trials. The most rigorous trials available are those called RCTs, or randomized controlled trials. These trials involve somewhere between 10,000 to 20,000 individuals, and the objective of these trials is to prove efficacy and safety. Then after those, and after a medication or a drug gets approved, then there's ongoing surveillance. And this can happen in many ways too. We have the VAERS, which is our vaccine adverse reporting system, which is a self-reporting system. And then there are numerous types of trials, from observation through complex ones, like the one done in Israel that enrolled more than 1.7 million individuals. In order for any medication or vaccine to be approved by the FDA, they expect that they go at least through 2 well-done clinical trials. And on top of that, what the FDA reviewers do is that they assess the benefits and the risks and uncertainties. And the benefits must outweigh those risks and uncertainties. There is something called the accelerated approval, which is an expedited process. And this was a pathway that was established in 1992. And this was used for certain drugs or medications that were tiered to life-threatening conditions. Through this path, many drugs have entered the market, mostly for HIV and cancer treatments. It is also important to say that once a medication or vaccine gets FDA approval, the drug maker is required to perform post-marketing trials. It's an ongoing surveillance, and they must demonstrate benefit and assess other side effects. And if further trials fail to prove benefits or major side effects occur, FDA may withdraw its approval. Currently in the US, we only have one vaccine that has approval by the FDA for 16 and older, and that's the Pfizer vaccine.
Okay, thank you. So Dr. Manga, we have been experiencing really high hospitalization rates for other causes different than COVID. So the question was, are these a consequence of the vaccinations?
No, they're not. One of the most important strategies that we have trying to prevent the spread of COVID-19 is social distancing. That's the accepted term. I don't like it. I personally use physical distancing because a consequence of this, many things have occurred. Number one is social isolation. And we have seen through the pandemic an increase of behavioral and mental disorders, including depression, increasing the rates of childhood obesity, and suicide rates. The other thing that it's an unintended consequence is medical care distancing. And in fact, throughout the pandemic, we have seen a dramatic decrease in visits to primary care, decrease overall immunization rates, and performance of preventive tests. And we live in a county which have a very high prevalence of chronic conditions, specifically diabetes, hypertension, and obesity. And if these chronic conditions gone unchecked and become uncontrolled, then many consequences can happen. And those can range from strokes, heart attacks, to kidney failure. And I believe that we are starting to see the consequences of medical distances in our emergency department.
Yeah, thank you. And I just want to remind our viewers right now, Dr. Manga, you're very familiar with the chronic diseases, because as I was reading your introduction, we now call it specialty clinic, but it was formerly known as the Chronic Disease Center. And so all of these that you just mentioned, you are very familiar with as you treat those patients who have those conditions here at Kaweah Health. Okay, so I'm going to ask you another, that people want to know if vaccines are causing things. So here's another question. COVID vaccines have been linked to increased blood clots, inflammation of the heart, and in theory, could those be a contributing factor to the increase in hospitalizations?
In theory, they could. So it is true that no vaccine is 100% safe. I want to go back about what we discussed at the beginning, the reactogenicity. mRNA vaccines are considered highly reactogenic, meaning if you get one of these vaccines, chances are you're going to have one of these effects. And most of them occur rapidly. Within 24 hours, they solve within 2 days. However, there are some that can be delayed, and those usually are like rashes, pruritus, which is like itchiness, and inflamed lymph nodes. These delayed effects can occur 5 to 14 days after you got your vaccine and are more common with the Moderna vaccine. I want to make an emphasis that if you do have those effects, that's not a contraindication for you getting your second shot. But in general, for any medication or vaccine to prove safety, it's a very difficult task. We need to take into account many things: how often the event happened, how close it is to the administration of the drug or the vaccine. So, effects like the ones that we just mentioned are very easy to spot. They occur frequently and they occur right after you get the injection. But for those that occur less frequent, then it's challenging. And we talk about randomized controlled trials, or RCTs, and the objective of those trials is to prove benefit or efficacy and safety. They enroll somewhere between 10 to 20,000 individuals, which this means is that with these studies, we're able to detect events that occur in about 1 in every 10,000 individuals. But if you have something that it's more rare, that occur less often, then you need vigorous surveillance. We talk about the VAERS, so that is very important. True, it relies on self-reporting, but it's especially good when those rare events that occur are of clinical significance and they don't occur in the general population. So it's easy to spot those using this system. But for others, when they don't occur as often or it's difficult to establish their relationship, then other types of studies are needed. And in Israel, an interesting study was just recently published. This study enrolled more than 1.7 million individuals. They use electronic medical records, and for each of these vaccinated individuals, they matched it with an individual that had similar characteristics, but that he or she was not vaccinated. And then they also studied people that actually had COVID-19. And this particular study did show that Pfizer or mRNA vaccines do have an increased frequency of certain things like myocarditis, pericarditis, inflamed lymph nodes. Of note, when they compare the frequency of these events in people that received the vaccine with people that actually had COVID, these same outcomes were far more frequent in people that had COVID than in people that had the vaccine.
Exactly.
I do want to explain a little bit more about this because it is important to understand. Then we need to look at to see who gets the side effects, and what they saw is that this actually occurs more frequently in young men. So between the ages of 12 to 29. And most of these cases were mild, and they were treated simply with anti-inflammatories. But there were cases that require ICU care. At this point in time, we don't know if you develop myocarditis, which is inflammation of the heart, or pericarditis, inflammation around the heart, with the first shot, if that predisposes you of another episode with the second shot. But the recommendation from expert is that you defer the second shot. We have not seen any cases of myocarditis associated with the vaccines at Kaweah Health. The other part that I want to talk about is the Johnson & Johnson vaccine. So in terms of the reactogenicity, Johnson & Johnson is far less reactogenic than the mRNA vaccines. But interesting, there has been an association with something called thrombosis with thrombocytopenia syndrome. So in the US, we have administered over 7 million doses of the J&J vaccine. And as of August 11, 42 cases have been confirmed of this syndrome, which basically, in a very simplistic way, is a syndrome where you have clots in unusual places and your platelets are low. And then when they dig into the information, trying to see who is getting this, they saw that it's more common in women that are young, 50 or younger, and also in people that had history of an immune-mediated syndrome with thrombosis and low platelets. So our recommendation, or the recommendation of the expert, is that the Johnson & Johnson vaccine should not be provided to younger women or people that have a history of this type of syndrome. We have not seen any cases either at Kaweah Health.
Okay, thank you. So we have a chat that has just come in, and it says, what is the hospital's response to the data coming out of the nation of Israel with regards to the SOR and COVID positive individuals, even though Israel is one of the most vaccinated nations in the world? Have either of you heard that?
Can you repeat the question again? What's the exact question?
So what is the hospital's response to the data coming out of the nation of Israel in regards to the SOR and COVID positive individuals, even though Israel is one of the most vaccinated nations? Have we heard a report that there has been a surge in COVID positive cases in Israel?
So in Israel, they reported that there has been an increase in cases, and that's what prompted the decision of offering a third dose of the mRNA vaccine for those individuals that are immunosuppressed. There's also prompted the idea of the individuals that have been vaccinated with mRNA vaccines will require boosters. That has not yet been approved in the United States, but it's coming, I think.
And Israel has already rolled out, I believe one of our community members had said they were rolling out their boosters a couple of weeks ago. So, okay, thank you. So Dr. Manga, for the individuals who have had COVID-19 and then they get reinfected, does the vaccination make an impact?
Most definitely. It still prevents serious complications. It still prevents hospitalizations.
Okay, thank you.
I'm just going to add a little bit, and this is not a study or anything, just come from practical experience, having worked as a clinical pharmacist in anticoagulation clinics, and working with a lot of people with genetic predispositions to through blood to have blood clots. People respond very uniquely to the COVID virus infection. I think a lot of it is based on their genetic makeup, right? There's a hyper response, a lot of inflammation that causes their lungs to have a difficulty exchanging oxygen. Infections can cause blood clots in and of themselves just from the cascade of effects that happen in the body. And so when you see, these minority reports coming out of unfortunate side effects to a very limited few people who receive vaccine in response to the vaccine, right, mounting that immune response, I wonder what would have been the effect had they had the full-blown disease of the virus with their genetic predisposition. We do see the effects of that in the hospital for sure. People just having just really, obviously, I mean, death to the point of death. So there is a genetic predisposition there, but the cases are so very few. And then again, to my point, I wonder what their response would have been to the actual COVID virus when they're just responding to the vaccine for it.
Okay, thank you. So Ryan, is it safe to get the vaccine if a person currently has COVID, or should they wait until the virus is completely out of their system?
Right. And so yeah, this kind of connects to the first question in terms of looking at the vaccine as a therapeutic. So in this sense, no. You wouldn't want to receive the vaccine while you are actively infected with the COVID virus. You would want to wait until you're fully recovered, to use that 10 to 14 day window, that you've been without a fever of 100.4 for at least 24 hours before you would start receiving the vaccine. But you want to make sure that you're fully recovered from the infection before you start your vaccine series. But you should, as soon as you're recovered, start the vaccine process.
Okay, thank you. So Dr. Manga, how long does the natural immunity last if a person has had COVID, and why are natural antibodies not taken into account for deciding if a vaccination is needed?
That's an interesting question, and we might not have a true answer to that question. We know that there has been just a recent study published that I'm sure the audience is aware of in healthcare workers who had COVID, and they analyzed them, and it was seen that natural immunity lasts up to 8 months after they had the disease. So it is true that after recovery from COVID-19, reinfection is rare in the month after the infection. So you may choose, if you had COVID, to delay your vaccination. However, you can also choose to get vaccinated. There's no contraindication. And in terms of why antibodies are not taken into account for deciding whether you should vaccinate it or not, it's because antibodies tell us just part of the story. So immunity is not only antibodies. We have humoral and cellular immune responses, and all those together are responsible to make us safe against the virus. Yes, we can measure all those things, but those things are very complex, they're difficult, they're time-consuming and costly.
Okay, thank you. So Ryan, is it true that people who have had COVID-19 can get really sick, more sick from the COVID vaccine than, say, somebody who hasn't had COVID?
Well, when you ask a person who works in the hospital really sick, that's a relative term. No, I think receiving the vaccine won't make you really sick. I think to the point, if you've had the infection before, you have some natural immunity floating around. You have some antibodies in there. So when you receive the vaccine, you'll likely have a more robust, response to it. So you have more aches, you may have a little subgrade fever, more fatigued than a person who has never been exposed to the COVID virus and receives their vaccine. Even amongst my own small group of friends, we all got vaccinated around the same time when the vaccine first released. For myself, didn't really have much. I felt maybe a little cloudy in my head for a day or two. I knew something was going on, but I didn't. I went to work the next day. And I have other friends that, I'm calling in, man. I don't feel good. Just achy and tired and lethargic, and it lasted for 24, 48 hours, and they were back. So it's highly variable. But I do think that if you were previously exposed to the virus, you might have, a little more robust response to the vaccine, but certainly not to the point of going to the ED or getting hospitalized. That's what I deem really sick. No, it wouldn't cause that.
Yeah, our CEO Gary Herpes, he said that people who are younger tend to get sicker from the vaccine, and so those of us who were middle-aged and we didn't get sick, we were kind of offended.
Yeah, right.
Okay, so here's a question that has just been submitted. Is it recommended to get the COVID vaccine if someone has already been vaccine injured? I'm going to take that as maybe they had a bad reaction to maybe vaccine the first dose?
Well,
Is that a term you have?
The term injured means. So let's kind of go back through the different things. If you have had any of the reactogenicity effects, which I hate to call side effects, they're expected effects, that's not a contraindication for you to get the second shot. If you have had an episode of myocarditis or pericarditis with your first shot of an mRNA vaccine, we don't know if getting a second shot may predispose you to a repeat episode, and hence we recommend against it. If you have had TTS, or the thrombosis with thrombocytopenia syndrome, that was just one shot, so technically that's all you needed, but you should not get that shot again because we don't know if that will predispose you to have another event. I'm not sure exactly, Ryan, if you want to comment more on that.
Well, yeah, I would say to the individual who asked that question, talk to your physician. They know your case, they know your history, they know what your reaction was, and what is their recommendation for you. It's hard to give a concrete answer when we really don't know what the person asking the question, what kind of response they had in the past in terms of injury.
Ryan, if you have doubts, like if you think that you might be severely allergic to any of these medicines, we do count with allergy specialists in town, and they can specifically evaluate for that and give you a specific recommendation.
Yeah.
Okay, thank you both. And I'm going to throw this one out for both of you because it was sent in. You mentioned, the question earlier mentioned the speed in which the vaccine came about. So this question is in reference to that. The question is commonly asked why there has not been a vaccine for HIV or herpes, for example, but the COVID vaccine was developed within 2 years.
Yeah.
Any thoughts on that?
Well, it's a different virus. It's a very different virus than the HIV virus or the herpes simplex virus. But what I would say is that the scientific community really needs to be applauded. This is Nobel Prize worthy development. And I think the earlier question was, was it rushed? Well, it was certainly expeditious, but I think that the term rushed implies that we overstepped rules or did things in a way that wasn't safe or controlled. So no, in that sense, it wasn't rushed, but it was absolutely expedited, right? A worldwide pandemic, and how did we respond? We needed something, right? We needed the vaccine, and we needed therapeutics too. We're still working on those. Therapeutics are much more difficult to develop therapeutic for viral infections. Vaccines are easier, but in terms of that question, it's a very good question. And honestly, to the person who asked that, I'm excited about what this means for future vaccine development. What we have learned in the scientific community over the last 2 years through the development of these vaccines, through the new technologies of mRNA vaccines, I think it opens up a whole new host of opportunity to develop vaccines for other diseases and conditions, right? Cancer, et cetera, that plague humanity. I would love to see that.
Okay, thank you. So Dr. Manga, why has the state mandated healthcare workers to get the COVID-19 vaccine?
I think that as healthcare workers, we have an ethical duty to our patients, and vaccines are part of that duty. We get vaccinated, we're protecting ourselves, we're protecting our patients, we're protecting our loved ones.
Okay, thank you. So Ryan, why is Kaweah Health marking non-disclosed status patients as unvaccinated versus undisclosed?
So we have three determinations, three buckets, I guess, that we put the patients in: vaccinated, unvaccinated, or undisclosed or unknown. There are patients who come into the hospital incapacitated, nonverbal, unable to respond to that. So we do not include the undisclosed or unknown in the unvaccinated population. There's three separate buckets that we put those patients in for reporting.
And we just want to clarify that we are going by what the patient tells us. That's how we're tracking vaccinations, correct?
Correct, yeah. And so some patients will come in and say, I don't want to disclose that, right? And
I just want to
clarify
clarify that if they do say that they are vaccinated, that data it's validated. They do look into the registry to confirm that they are actually vaccinated.
Okay, thank you. And I believe you referred to that earlier, Dr. Manga, as being a very time-consuming process and a lot of steps involved. Okay, thank you. So Ryan, my granddaughter is 11. And when will individuals under the age of 12 be eligible to receive the vaccine?
Well, it depends on when your granddaughter's birthday is, when she'll be able to get the vaccine. So Pfizer was first to market, and Pfizer will be first to market, likely for their approval for 5 to 12-year-olds. Again, there's no set date on this, but they did say perhaps late September or early fall. They'll be applying for their EUA, their emergency use approval with the FDA for ages 5 to 12. And then they're already studying 6 months to 5 and younger, or up to 5. It is a separate FDA application. Moderna, again, came in after Pfizer. They're looking at the end of the year for their submission to the FDA for 5 to 12-year-old immunizations. There's active trials going on as we speak on the effectiveness and safety and the dosage for those.
Okay, thank you. So Dr. Manga, this question was sent in. So the vaccine was created to fight against the previous variant of COVID. So does the vaccine help fight against this Delta variant, or does it not? And is that the reason why we're seeing so many new cases of the Delta?
So it still works. It doesn't work as good as for the other variants. And so all the viruses mutate. And when they mutate, it's an evolutionary thing, right? So what they're trying to do is to survive whatever conditions they do. And we're giving them a vaccine. And so the virus is trying to overcome that. They still work against severe disease, but it does not work as good. So definitely the new variant is responsible for the new surge, because this variant, it's more transmissible than the prior ones, actually has a shorter incubation period, and it's more infectious. So the amount of virus that you can have in your nose if you get infected, it's a lot more than it used to be for the older variants. And that comes back to what we need to do. We need to get vaccinated, we need to use a mask when we are indoor, and we need to maintain physical distance.
Okay, thank you. So Ryan, how long will it take to build vaccine herd immunity?
It's a great question. I think that's being talked about a lot. I think it's probably more appropriate to say what will it take to get there, because how long depends on how quickly folks get vaccinated. When you look about what it takes to achieve herd immunity, you often hear a percentage of the people in the society who have to become vaccinated or immune to achieve that herd immunity. That percentage, that number of people that we need to get vaccinated is directly correlated to how virulent or how infectious that disease is. Measles, for instance. Measles is one of the most contagious viruses on the face of the planet. You have to have a 94% herd immunity or immunization rate in your community to have that herd immunity. That's huge, right? But we've done it. We've done it. Measles doesn't really exist other than little outbreaks here and there in the developed world. Why? Because we're immunized. Because part of the childhood immunization series, right? Smallpox, polio. We have done it, and we'll do it with COVID. COVID, from what we see, needs about 70% of what I've read in terms of 70% of society needs to be immunized in order to achieve herd immunity. And that breaks the chain of spread, right? Now, again, we know we have breakthrough cases. We know that immunity wanes after a year. And so looking at probably on a long view, like an annual flu shot, I foresee a annual Volvid shot, right? It's a combo of flu and COVID together. And because of the way that these viruses mutate, unlike polio, doesn't mutate like these respiratory viruses do, and therefore boosters aren't needed for polio. But these viruses, the way they behave and the way they mutate, you know, we've cracked the code. We just have to make small manipulations now to keep in front of it.
Okay, so I said at the beginning, Tulare County is 32.9% vaccinated, and you threw out 70%. So we have a ways to go, but
that's why we're here tonight.
That's why we're here.
Yeah. I've got a friend right now in the hospital. He just hiked the John Muir Trail and was healthy as an ox in his late 30s, and he got COVID, got down to the 80s in his O2 saturations, and praise God he got to the hospital on time, but and wasn't vaccinated, right? So here we go.
Yeah,
we got it. We just got to convince folks that it's okay. It's okay. It's the right thing.
Okay, thank you, Ryan. Ryan, I'm coming back to you with this one. So this community member has a question about medical records being private. So her question is, I thought medical records were supposed to be private, and how can Kaweah Health post whether or not a patient is vaccinated or unvaccinated?
We can, and we don't. We do not publish, patient names and their vaccination status. We do, report our statistics, the number of patients in the hospital or on the ventilators, as required by the state. And so we pride ourselves on being a transparent organization. We really want the community to know, what's going on. And it helps, again, to our point, reinforce the effectiveness of the vaccine by just letting the community know those statistics. And so, yeah, absolutely, that information is private to the patient level and never released.
Okay, thank you. So Dr. Manga, do you know how many of the patients who have died with COVID were vaccinated?
I have the data for our county from July 25th through August 25th. So 290 people have been hospitalized during that time frame. Of those, 252 were not vaccinated and 38 were vaccinated. 52 patients ended up in the ICU. Of those 52 patients, 51 were not vaccinated and 1 was vaccinated. And of those, 11 patients passed away, 10 were vaccinated and 1 was not vaccinated. Now, I want to make clear that they ended up with COVID in the hospital. I am not saying that the principal reason for admission was COVID-19 or that they died from COVID-19.
Okay, thank you. So Dr. Manga, the question is being asked again. So how many people with and I don't even know if we know this, do we know the breakdown of how many people with natural immunity are getting COVID?
No, I don't have the answer to that. And you have to take into account that the studies have been done at different moments of the pandemic. So if I had COVID at the beginning of the pandemic, now we're with another animal. It's different. So I might not be immune against this variant. We do know that in general, immunity kind of lasts for a while. It can last up to 8 months. But we also know that a person that has had COVID and it's unvaccinated has two plus times higher possibility of getting COVID than a person that it is vaccinated. So once again, I don't have an exact data on that, but even if you had COVID, you should get vaccinated.
Right. Okay, thank you. So this was chatted in. Given the fact that we just put a large number of unvaccinated children back into schools with no physical distancing, is that why we're seeing the increase in COVID infections in children under 12?
Difficult question to answer. It's possible. We don't have a vaccine for kids younger than 12. So a way for us to protect our kids is also for us getting vaccinated. Once again, we do know that this virus, it is more infectious. It transmits easier than the prior variants. So if we are together, we're not vaccinated, we have higher chances of developing the disease.
Okay, thank you. So Ryan, we've referenced boosters or the third vaccine. So do you know when those are going to be available to our community, or when are they going to be offered to Kaweah Health employees?
It's a great question. And Dr. Manga does such a great job of describing it. But there is a distinction between a booster and a third dose, right? So Dr. Manga mentioned from the Israeli study that came out, is really where we realized that, you know, immunocompromised folks simply did not mount a robust enough response to the 2-dose vaccine regimen because they're immunocompromised. You know, when you give the first dose to get a little bit of a bump in their immune system, they get a second dose, but they need to get here to achieve immunity. So that third dose gets them enough immune response and enough antibody concentration in their blood to prevent, you know, infection or severe disease. So that's a third dose series, right? Versus booster dose, right? So the general population got that first dose, got that second dose, and now, you know, the second dose is over the level needed to have immunity. But then after 8 months of time go by, that immunity starts to decline, and therefore you start dipping below that minimum number of antibodies you need floating around in your body. So when you get exposed to the virus, it can mount a response against it. And it looks about 8 months is what they're finding after that 2-dose series, that an additional booster dose is required to boost your immune system back up over that threshold so you can maintain that immunity. It's currently not FDA approved. The FDA and the CDC, I think, everybody keeps saying September 20th. I guess that's when their national committee meets to review all the data, I guess. But starting September 20th is what we're predicting, that the FDA and CDC will come out with the EUA approval for the booster shot for the vaccines. Now, so if you've been 8 months since your second dose, you would be eligible for a booster shot. Now, you would need to receive the same type of vaccine. You had Pfizer, Moderna, or Janssen, you would want to get that. Depending on, I'm assuming, I don't know if all three are going to get EUA approval at one time, or if Janssen won't, or I don't know. We'll have to wait and see. And yes, we are actively talking about how we can get our healthcare providers and staff that booster shot in short order, because we're all hitting that 8-month window right now. We certainly don't want, you know, all of our staff to become ill and sick and not be able to work and care for our community, because we're already, you know, desperately understaffed as it is. So we talked to the county coalition this morning about what we can do collectively as a coalition, because it's not just Kaweah, right? It's Adventist, it's Sierra View, it's Family Health Network, it's ARIA, it's all the private physicians in the community and their staff that really need that booster coming up. It's a lot of people in a short period of time, and you know, we don't have the resources in place today to accomplish that level of immunization again. So we're trying to mobilize the troops and get that done.
And I do want to say that the third dose is available now for all our healthcare workers and our community. It's for a very specific subgroup of immunocompromised people, and we can probably publish a list of who will qualify because it's very specific. People that take certain type of medications, that had an organ transplant or a blood cell transplant in the last couple of years. It's very specific. It's not because you have some chronic disease that you will qualify for the third dose, and we can definitely publish those.
Okay, so here's a question for you. So we consider somebody fully vaccinated when they've had that second dose. So is that going to apply now once the third dose is going to be released? Will we not be considered fully vaccinated without that third dose?
So I want to clarify because I think we're confusing the terms here. So the third, to immunocompromised people, certain group of immunocompromised people requires a 3 series of the mRNA vaccines. We don't have any data yet on the Johnson & Johnson. So we're talking here specifically about the mRNA vaccines. So for me, if I'm immunocompromised, if I have any of these conditions or take any of these specific medications, for me to be considered fully immunized, I will have to get those 3 doses. Now, everyone else that is not immunocompromised, if I'm not immunocompromised, you're fully vaccinated after the 2 doses. And 2 weeks have needed to pass for you to say that you are now immune.
I think the question is, when this booster dose gets approved, 8-month post second dose, are people who receive their 2 doses after their 8 months considered not fully immunized if they don't get their booster? And I haven't heard any determinations of that or how, CDC or a state or anybody else is going to treat that to this point.
And it's a difficult question to answer. And you might go back to vaccines like tetanus shots. For example, you're supposed to receive the booster every 10 years. A lot of people do not. But if something happens in between, and if you have a dirty wound, if you visit the ED, they will give it to you. Or if you get pregnant and you're going to have a baby, they will give it to you. So I think the answer to that will come with time, and what exactly we need to do and how often those boosters will need to be given.
Okay, thank you both. So, Ryan or Dr. Manga, does Kaweah Health currently offer COVID antibody therapy?
Do you want to go answer that, Ryan?
Either one of you. Sorry.
No, I don't believe we do any infusions of antibody therapy.
So what?
Plasma,
are you talking about monoclonal antibodies or plasma?
Plasma.
The question is just COVID antibody therapy, so probably plasma, right?
Okay, so plasma, we thought it worked, but then after further studies, it doesn't work, so we no longer offer plasma therapy.
Okay, thank you. So what current treatments are available for patients with COVID-19 if they are hospitalized or if they've been exposed? And are those treatments as effective as the vaccine? Ryan, you want to take that?
So again, not wanting to confuse treatment with prevention. If you're actively infected in the hospital, we're not going to give you a vaccine to treat you. It's too late for that. We'll have to wait till you recover to protect you further. To date, there's only one FDA-approved, fully approved therapeutic agent for COVID infection, and that's remdesivir, an IV medication given during admission to the hospital. It's IV, and it's really for a more severe disease. There are other medications I know have been studied pretty extensively across the world. Hydrochloroquine being one of them. Hydrochloroquine, ivermectin has been in the news a lot lately. And then there was one more I had it listed here. Sorry. And in combination with azithromycin or not. a lot of controversy, a lot of, I get friends text me all the time, YouTube videos of a physician standing up in front of a board or something and just swearing by this or that. And again, we're all searching for answers, right? We all want to put our hope in something. We all want that magic bullet just takes it all away. And we can feel safe with or protected by and give us some peace. I understand that. I fully understand that. But the fact of the matter is, you really have to objectively look at the data, look at what the data is telling us. And unfortunately, to date, the only one therapeutic drug that we really have FDA approved is remdesivir. Now, we have other agents we use, dexamethasone, absolutely, right? Knock down that inflammation. IV dexamethasone is used, but a lot of it's supportive care. There was when I looked at just today, I catch myself up with the data because it keeps pouring in. Maybe I'm missing something. So I blocked a couple hours today. I printed up, the 14 studies done in 14 studies done in 12 countries around the world with ivermectin. The CDC doesn't come out saying that they disapprove. They don't support its use. They can't. There are some small studies. These studies, guys, listen. The largest study was retrospective, about 5,000 patients done in Peru, and that showed actually increased mortality with ivermectin in the inpatient setting. The other studies are literally 60 patients here, 130 patients there, 44 patients here, done in Bangladesh and Peru and India, Mexico and Florida. And so they just were not, the studies are not big enough. They don't have statistical power to tell you one thing worked or another didn't. They were not well designed in terms of blinded. Some were placebo controlled. And so the weight of the evidence just doesn't support ivermectin being used as a therapeutic agent for COVID. Ivermectin it won the Nobel Peace Prize in 2015. It is a wonderful drug. It has pleiotropic effects, right? It has some anti-inflammatory effect. And it's very unique in its mechanism that it doesn't attack the parasite or whatever. It actually manipulates the machinery inside the human body, which makes it have a broad spectrum use. When you test ivermectin in what we call in vitro, meaning in a test tube, we see that it has antiviral activity. We see that it does help against viruses. But there's a big leap between in vitro and in vivo, in life, in living organisms. But taking the results off the bench and then putting them inside of living organisms and seeing those same results, there's a big chasm there. And that chasm is dictated by what we call pharmacodynamics and pharmacotherapeutics, right? The concentration, I could put a 1,000-fold concentration inside this test tube and show that it kills virus. But can I put that concentration inside a human being and not cause cancer, not cause cardiac arrhythmias, not cause other things? Can I achieve the same, concentration inside the human body in the lung tissue by something I put in the arm or put in my mouth and get my stomach, and I had to get that chemical into my lungs to get the same effect that I just saw in a test tube? Very, very different and very complicated and very, you have to be very careful, right? That's why we can't just apply what we, gosh, it sure seems make sense. We saw this result in the test tube, let's just put it in a bunch of people. That's unethical, it's dangerous. And so we have to go with the weight of the evidence. And I'm hopeful that we'll find more therapeutic agents. But at the end of the day, viral infections are just very difficult to treat therapeutically. And I'll let Dr. Manga chime in on that.
I just want to I know we're running out of time, so I want to make a couple of comments. We do have a new therapeutic that is soon going to be available for the outpatient population. It's called Regeneron. And this is going to be specific also for people that are at high risk and get in contact with the virus. And we can send information out to the community so they are aware. In terms of ivermectin, what I want to summarize is that all the studies that had been done were flawed studies. They were not done properly, number one. Number two, when they did the in vitro studies, what they found is that in order to be effective, against COVID-19, you will require a dose that is at least 6 times greater than the normal dose that it's given for any other condition. So it will be toxic for an individual. Now that doesn't mean that ivermectin is a bad drug. It's an excellent drug. We use it for certain parasites. We use it for difficult cases of scabies. It just doesn't work for COVID-19. What you hear are anecdotes, and we have to differentiate between an anecdotal data and well-designed studies. Those are very rigorous, and in order to establish that efficacy and that safety, they have to go through all those rigorous studies, and ivermectin did not.
And being a pharmacist, understanding how drugs get developed and approved, you always read things with a jaundiced eye. I'm always like, well, who did that study? Who paid for that study? And the very makers of ivermectin, Merck, right? The pharmaceutical company, Merck, they say, don't use ivermectin for COVID. And so the one company who had stand to make billions off of it is not, right? Because the evidence just isn't there.
Right. Okay, thank you for that. I have one final question that has come in. So in regards to the booster shots, it looks like they are going to be released about the same time as we normally are receiving flu shots. So is there a certain time, a length of time in between the flu shot and the COVID booster that we need to hold off? Do we need to, not take them at the same time? What is the length of time?
Nope, there is none. You can take them together.
There is no issue at the beginning because we didn't know exactly. We were asking individuals to hold at least 2 weeks in between vaccinations. But now we know that you can get all the vaccinations together.
And really for that, Dr. Manga, the reason is we want to say the safety of the COVID vaccine, right? And how can we attribute something that happened, a side effect or what have you, if you receive both at the same time? But now we've had 3.1 billion people in the world who received the COVID vaccine. We understand its safety now.
Okay, thank you. So Dr. Manga, before I close out the meeting, I would like you to just give a general message to our community as our medical chief of staff. Can you do that for me?
Of course, thank you. Well, thank you for the opportunity. I hope that this conversation brought reassurance to those that have been vaccinated. And for those that have not, it is my hope that we were able to open a window, even if it's for further discussion, and for you to be able to take a well-informed decision. I know that our focus today was about vaccines, but I also want to remind you of the importance of using masks when you are in indoor settings. I also want to remind you of the importance of physical distancing, avoiding social isolation, and distancing yourself from medical care. Thank you.
Okay, well, thank you both, Dr. Manga and Ryan Gates, for coming on and answering all of the questions. And thanks to our viewers for spending part of their afternoon with us. And we hope you learned something during this session. And we also hope that you know that Kaweah Health is working hard to care for you and your families and this community. So we hope you feel better informed about the COVID-19 vaccine, and we'll see you soon. Thank you.